Okay, guys, chapter 18, gastrointestinal and urologic emergencies. How are you guys? I hope that you're doing well. I hope you got to see my Monday, April 6th welcome video, just kind of going over the state of the class. If you didn't get the opportunity to watch that, go one video back and check it out. It's informative. We have some plans for some meetings going forward, and hopefully you guys are able to attend. Hopefully my head stays up here in this little corner for the duration of the video. If I drift, I apologize. But we're going to talk about gastrointestinal emergencies and how it relates to EMS. Why do we need to know about that? Because abdominal pain is a common complaint. We get called for abdominal pain fairly often. So as an EMT, we don't need to be able to determine the cause of the abdominal pain, but we need to be able to recognize when it is a life-threatening emergency. So we're going to learn about the anatomy and physiology of it. Right? When we talk about the abdomen, that cavity is containing the gastrointestinal system, the genital system, and the urinary system, right? And we have a combination of solid and hollow organs all in there. An injury to a solid organ can cause shock and bleeding, right? So that solid organ is able to break and bleed, causing a life-threatening injury, right? Breaches of hollow organs can cause the contents to leak and contaminate into the abdominal cavity. That can lead to sepsis, that can lead to infection, and those are life-threatening injuries. So here, and again, this is in the book if you want to follow along on the book, but I think you should be able to see it really good on the screen. The anatomy of the abdominal cavity. So here we have the solid organs, and you see that there on the screen: the liver, the kidneys, female ovaries, the pancreas, and the spleen. So those are solid. And for hollow organs, we have the gallbladder, the ureter, the large intestine, the small intestine, the stomach, female fallopian tubes, the urinary bladder, and the uterus. So be familiar with that anatomy and physiology. But what about the GI system? So gastrointestinal system is responsible for our digestion process. Digestion starts when we chew our food. So as soon as we start to break it down with our teeth, we are beginning the digestive process, and with saliva, we're starting to break it down. The stomach becomes the main digestive organ. We have a liver, and that assists in digestion by secreting bile, filtering toxic substances, as well as creating glucose stores around it on the outside. We contain our glucose stores on the outside of the liver. And we have a gallbladder. The gallbladder is a reservoir for bile. We also have our small intestine. So you've seen this before, I believe. It consists of the duodenum, the jejunum, and the ileum. Duodenum, jejunum, and ileum. Our colon is our large intestine, and that is where food that is not broken down comes into the colon. Water is absorbed, right? That's where we maintain our hydration, and that is where stool is formed. Pardon me. And the spleen is located in the abdomen, but it has no digestive functions. So talking about the genital system, the abdominal space also holds our reproductive organs. We'll talk about that more later on. Urinary system, right? Controls the discharge of waste materials that is filtered from our kidneys, right? 2 kidneys, one on each side of the body. They are retroperitoneal organs. The ureters join the kidneys to the bladder, and the bladder is located behind the pubic symphysis. So if you're familiar with the pubic symphysis, you'll understand that the bladder is right behind it, maybe just a little bit above. The bladder empties urine outside of the body through the urethra. And here you see the bladder would sit just behind the pubic symphysis, the kidneys being retroperitoneal, and this is male anatomy. So you see the urethra exits through the penis. Pathophysiology, right? This is what we need to know. This is the meat and potatoes of what we're doing. The abdominal cavity and organs are lined by the peritoneum. Right, parietal, lots of P's. Parietal peritoneum lines the walls of the abdominal cavity, right? The visceral peritoneum covers the organs, right? Remember, parietal, outside, visceral, against the organs. Foreign materials such as blood, pus, or bile can irritate that layer, that membrane. Acute abdomen refers to the sudden onset of abdominal pain. So we would say that anytime somebody has abdominal pain and it just came on suddenly, that they have an acute abdomen. We don't know. Oftentimes we don't know what's going on with acute abdominal pain. But it's often associated with severe progressive problems. An infection is a big one. If we go back a slide, foreign materials such as blood, pus, and bile can irritate the peritoneum by causing an infection. Right? Peritonitis is inflammation of the peritoneum, and it can cause ileus. Diverticulitis, cholecystitis, and acute appendicitis are all disease disorders that affect the abdominal cavity as well. So, abdominal pain. This is the one. This is the most common thing that we're going to see when we're dealing with abdominal, medical abdominal complaints that aren't trauma. Two types of nerves supply the peritoneum, right? The parietal peritoneum is supplied by the same nerves that supply the skin of the abdomen. The visceral peritoneum is supplied by the autonomic nervous system. And these nerves produce referred pain. So referred pain is something that is a pain that you actually feel somewhere else. So what are some causes of acute abdominal pain? Ulcers. Protective layer of the mucus lining erodes, and that allows the acid to eat into the organ, right? So stomach acid is starting to eat into the stomach muscle, and it is causing an acute abdominal pain. Gallstones may form and block the gallbladder's outlet. That leads to cholecystitis. Pancreatitis is an inflammation of the pancreas. Remember, anytime you see itis, we're talking about inflammation of. Appendicitis, inflammation of the appendix. Gastrointestinal hemorrhage can be a symptom of another disease. It could be a symptom of stomach ulcers. It can be acute. It can be chronic, meaning it's gone on for a very long time, or it has come on suddenly, and this is a new thing that this patient is experiencing. Esophagitis, the lining of the esophagus becomes inflamed by infection or acids from the stomach, like GERD. So gastroesophageal reflux disease is a chronic reflux of stomach acid that causes erosion to the lining of the esophagus. And a very life-threatening emergency would be esophageal varices. When the pressure within blood vessels that surround the esophagus gets too high, they can burst, and we can get uncontrolled bleeding into the esophagus. Those are high pressure, high volume vessels, and patients often die from esophageal varices. Mallory-Weiss syndrome, the junction between the esophagus and the stomach tears, causing severe bleeding. That would be high up pain and vomiting blood, things like that. Gastroenteritis, infection from a bacterial or viral organisms that are caused by non-infectious conditions. Diverticulitis, fecal matter becomes caught in the colon walls, causing inflammation and infection. Hemorrhoids, we all know what hemorrhoids are. They're created by the swelling and inflammation of blood vessels surrounding the rectum. Cystitis or a bladder infection is common, also called urinary tract infection. So in the elderly and women, we see a lot, oftentimes, bladder infections or urinary tract infections. It's usually accompanied by foul-smelling urine, fever, and can lead to sepsis. Sepsis being a very severe disorder. Kidneys play a major role in maintaining homeostasis. So the kidneys fail. Uremia results when patients have high urea levels. They get an altered mental status. They get combative. They need to go to the hospital significantly. It can oftentimes be hard to get a patient with high urea levels to the hospital because they have an altered mental status. Kidney stones can grow over time, and they can cause blockages, severe pain, lower back pain, abdominal pain, flank pain. These patients have a significant amount of pain. If you've ever had a kidney stone, you're sitting there nodding your head right now. Acute kidney failure causes a sudden decrease in kidney function. It can be reversible with a prompt diagnosis and treatment. Chronic kidney failure is progressive and usually results in irreversible damage. Those patients require dialysis. And if you get into the EMS business of transport, you'll find that dialysis patients are frequently transported by ambulance to and from their appointments. That's a very common thing that we see. Female reproductive organs, right? Gynecologic problems are a common cause of acute abdominal pain. Lower quadrant pain may relate to ovaries, fallopian tubes, and uterus. Some other organ systems, the aorta lies immediately behind the peritoneum. Weak areas can result in abdominal aortic aneurysms, or a AAA. Can be difficult to detect. We need to use extreme caution when we're assessing or detecting a AAA, right? We could push too hard on the abdomen and we can cause it to tear, we could cause it to rupture or burst. And when the aorta, right, the largest vessel there coming off of our heart into our trunk, if that ruptures, the patient will die oftentimes within seconds. Pneumonia can cause ileus and abdominal pain. So other systems include hernias, right? Protrusion of an organ through the opening in the body cavity where it doesn't belong. This might not always produce a noticeable mass or a lump. Oftentimes it does. You'll have the patient exposed to their stomach and you'll see a big mass there in their abdomen. And if it's there, oftentimes we'll say, I don't know, it doesn't hurt, doesn't do anything. But if it strangulates, if it's cutting off the blood supply to a vital organ, it's going to cause pain. It is a serious medical emergency. Serious hernia signs and symptoms: formerly reproducible mass that's no longer reproducible, pain at the hernia site, tenderness when the hernia is palpated, red or blue skin discoloration, and that's showing a lack of blood flow. So what do we do for these patients? And again, you'll find that this is a common theme in all of these slideshows, right? When we're talking PowerPoint here, Jones and Bartlett does this. We talk about what these disease pathways look like and how are we going to assess these abdominal pains. So again, scene size up, scene safety, BSI. Is it a mechanism of injury or is it a nature of illness? Airway, breathing. Are they breathing? Is it normal? Oftentimes, they may appear to be in distress. They're because of the pain in their abdomen, for whatever the cause may be, it may make them appear as though they are having a hard time breathing. So we need to assess their airway. We need to assess their breathing status and make sure it's adequate. Same thing, circulation. Ask about blood in their vomit, black or tarry stools. That is signs of blood coming up. That's signs of blood coming out in stool. And we need to know why the blood is there, right? Check pulses in both arms and make a transport decision. Do we need to take them right away? Or do we have time to sit on scene, get a set of vital signs, and get a really good history and figure out what's going on? Oftentimes, people call us for these abdominal pains, and it's not a life-threatening emergency. These are one of those situations where we might not have to stay and play, we might not have to load and go. We could stay and play with these patients. So what do we do? Sample history, nausea, vomiting. Do they have any? Have they had difficulty having a bowel movement? Have they had frequent bowel movements? Weight loss. Are they belching? Do they have excess gas? Do they have pain? Where's their pain? When did it start? Where does it go? Does it go anywhere? Oftentimes you'll hear them say, I have pain here in my left upper quadrant and also in my shoulder. So that would be an example of referred pain. Other signs and symptoms, are they pale, sweaty? Are they lightheaded or dizzy? Do they have chest pain along with this? Do they have shortness of breath? What do their vital signs look like? Physical examination, right? Palpating the abdomen. So what we're doing is we're looking or feeling with our hands for tenderness. We want to see what the abdomen looks like, so we need to expose it. We need to press gently. So if they say right upper quadrant pain, because we divide it into 4, right upper quadrant pain, maybe we would start with the left upper quadrant, left lower quadrant, right lower quadrant, and go to the right upper quadrant last where they have the pain and palpate gently and while we expose. So when we're pushing, do we see them wince as we push? When we let go, do they have pain when we let go? We would call that rebound tenderness. Do we feel anything? Do we feel a pulse, a strong pulse? Or that would be indication of maybe a aortic aneurysm, high pressure pulse felt through the aorta on abdominal palpation. And then vital signs, respiratory rate, pulse rate, blood pressure. So these people could have a low blood pressure because they may be shocky in a bleeding situation. Low blood pressure, altered mental status, high heart rate, rapid respiratory rate, pale, sweaty skin, things like that. All part of our assessment. We need to look at that for all of these patients. And frequent reassessment is important. So if we think we're dealing with something like a AAA, aortic aneurysm, these patients can go from stable to unstable very quickly. So reassessment is important. And having an idea of what's going on by getting a history is also very important with these patients. It gives us the best way to have an idea of what's going on. Oftentimes these situations are chronic and they have an acute flare-up of pain. So somebody says, I have chronic kidney stones and I usually have it under control, but now I'm having pain. I'm pretty confident that this is the same pain as a kidney stone. They're often pretty good at knowing what the cause of their pain is. So, emergency medical care. We don't do anything as EMTs, as paramedics even, to treat the causes of acute abdominal pain. That's above our scope of practice. That's something they need radiology studies for, blood work, and the doctors will eventually refer them off to a specialist. Even in the emergency room, they're not doing rapid treatment for acute abdominal emergencies. But we need to take some steps to comfort these patients, right? And lessen the effects of shock. What can we do? Treat them for signs of shock, even if obvious signs of shock are not necessarily apparent. Be a step ahead. Be ready for that. Low flow oxygen can make them comfortable. If their pulse ox is below 94, always give them oxygen. After completing our patient care, we clean the ambulance, we clean our equipment, and we wash our hands. Dialysis emergencies. The only definitive treatment for chronic kidney failure is dialysis. Lots of people are on dialysis. There's dialysis clinics all over the place. It filters the blood, it cleans out toxins, and it returns the blood back to the body. So if you're not familiar with it, the patient gets hooked up to a machine through a port in their body. The blood is taken out of their body, put through a filtration machine that is, right there next to them, and then cleaned and put back into the body. So these machines are essentially outside of the body kidneys, and if these patients miss their dialysis treatments, it can have a negative effect on them. They can have pulmonary edema, hypertension, fluid gain. Some ambulance services transport patients to and from dialysis centers. It's sometimes all that they do, and a lot of new EMTs go into that job. Dialysis machines function just like a normal kidney, right? So what can happen? Hypotension from dialysis, muscle cramps, nausea, vomiting, hemorrhage, or infection of the access site. That's probably the most common thing that we'll see is bleeding dialysis ports, and they bleed. They're major arteries and veins. An artery and a vein meets together at the port site, takes blood out, puts blood back in. So that is the management of dialysis emergencies. That is the management of abdominal emergencies. For us, it is very common to summarize, but we do not really do too much for them. Keep them comfortable, keep them warm if they're in shock, and make sure we monitor them. Some patients require advanced life support. Some patients do not. I would say that the majority do not. But again, it's all situational dependent, and a good assessment is going to give you the answers that you're going to want to need. So that's the end of chapter 18 here, and we are going to move on to chapter 19. I hope you enjoyed this video. I hope you followed along in your book, and if you're still watching, thanks a lot.